Hello, everybody. Thanks for joining Single Payer Radio during WFMP's Spring 2023 Membership and Pledge Drive. We're celebrating our 6th year going on the air. WFMP 106.5 forwardradio.org. First off, thanks to everyone listening and supporting our all-volunteer media project. And to celebrate, we're having a party, literally. Mark your calendar, Saturday evening, April the 8th, 6:30 to 8:30 at the Core, K-O-R-E, Gallery, 942 East Kentucky. We've got free live music, drinks, food. We want you to stop by. We want to see you and thank you. Mike Flynn will be there. Gene, any plans?
I don't know yet.
Okay, good deal. In the meantime, if you haven't become a member, now's the time. Go to forwardradio.org. Donate any amount. No amount is too small. It all matters. And if your nonprofit isn't a community partner, go to forwardradio.org and take a look. Consider your organization becoming a community partner. Kentuckians for Single Payer Healthcare was the first community partner at this station, and we plan on renewing our partnership during this membership drive. And a reminder, all contributions are tax deductible. If you have questions, go to forwardradio.org, click the contact button, and Ruth or someone from the station will get back with you and answer any questions you have. For new listeners, we broadcast our program from the historic Hayburn Building in downtown Louisville. This show is a project of Kentuckians for Single Payer Healthcare, and we are an affiliate of the Kentucky chapter of Physicians for a National Health Program. We have this program because our current fragmented care system costs twice as much as in other developed countries and delivers worse outcomes. Tens of thousands of Americans die unnecessarily each year because they can't access care. And over 100 million Americans carry medical debt, which leads many into bankruptcy. Kentuckians for Single Payer Healthcare also works to stop the Wall Street takeover of Medicare, and we oppose the privatization of the VA system. Learn more about the group and its efforts at kyhealthcare.org. Everybody in, nobody out. The views and opinions expressed on our show are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. Single Payer Radio can be heard on WFMP 106.5 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our radio signal, you can live stream us. If you miss a show, you can go to forwardradio.org/singlepayerradio. WFMP is an all-volunteer station. We rely on the community for your ideas and our funding. Please join us, especially during our membership drive, forwardradio.org. And very briefly, guys, last October, Governor Andy Beshear announced that through executive action, Kentucky Medicaid recipients, that's about 900,000 of our neighbors, would gain coverage for their vision, dental, and hearing. That was a step forward, thank goodness. Our state legislature, I believe it was last week, passed a bill that would take that part of Medicaid, they would take that away from our neighbors. that's where we are. Mike?
Yeah, this is Michael Flynn, retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer that any comments I make during this program represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville.
This is Eugene Shavely. I'm a retired general surgeon from Campbellsville, Kentucky. Again, my reviews, comments do not represent the University of Louisville or the Department of Surgery, nor Taylor Regional Hospital in Campbellsville, Kentucky.
Well, we have a special guest today, Ted Young. Ted is a surgeon, a clinical professor of surgery at McMaster University in Hamilton, Ontario. He did medical school and a general surgical residency at the University of Toronto, surgical oncology fellowship at Princess Margaret Hospital in Toronto, and a head and neck surgery fellowship at Roswell Park in Buffalo, New York. He and I are longtime members of the Society of Head and Neck Surgeons, and he was president in 1995. Ted, if there's anything about that I have gotten incorrect, you can correct it when we turn this over to you. Now, Ted has come on to talk with us about the Canadian healthcare system, Medicare for All, which is focused on providing healthcare for the Canadian citizens. And we're going to compare that with the U.S. healthcare industry, which is focused on extracting profit from healthcare activities. So Ted, before we begin the conversation, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them. And then Gene will start off with one of those questions that he sent you that was unreadable. So the floor is yours.
Thanks, Mike. Pleasure to be here again. I enjoyed our discussion. Must be, I don't know, was it a year ago?
It was about a year ago, yeah.
For your audience, when I told my wife I was doing this event, she said, "You're going to talk about the Canadian healthcare system? It's a disaster. It's in crisis mode." And I laughed because it's always been that way. Healthcare in every country is always in various stages of crisis. And I'll come back to that in a minute. And certainly I should be an expert on the Canadian healthcare system, both as a user, and I have an appointment to see a plastic surgeon when we finish this Zoom because I've got a mallet finger, or called a baseball finger, which I got packing stuffing suitcases into the back of a car on my way to the airport. And what it is it's a little injury at the tip of the finger where a tendon gets damaged. And that will be a straightforward evaluation. I have access to the healthcare system better than most because I'm in it. I have access to a plastic surgeon that I texted yesterday and said, I've got a temporary splint on this. And she texts back, said, "Oh, there's a much better splint. Come in and we see you. We'll do it tomorrow." If I was a member of the public and I had this injury and came back from holiday with a temporary splint on, I'd phone my family doctor if I had one. And as my wife said, we're in crisis mode because about 25% of the population of Canada doesn't have a family doctor. And access to a family doctor is access to the healthcare system. If you've got a family doctor that knows you, they'll know that you're on a slew of medications. And when you call with a problem or go to see them, they think, "Oh, shoot, I wonder if the medication I prescribed a month ago is causing some of those symptoms, et cetera, et cetera." So having a family doctor is a major advantage to someone who's sick, or even someone who's well and needs vaccines before going to Africa, for example. However, if I didn't have a family doctor and I was a normal member of the public and I had this injury, I'd go to the emergency department. And yes, I might have to wait 6 hours to see someone because the healthcare system has been overwhelmed since COVID. And part of the reason for that is that nurses and doctors, some just got burnout, left the system. So we're short nurses in some places. Some emergency departments in smaller areas have to close for 8 hours a day. But I'd go to the emergency department. I'm in a big city. I'd go to the emergency department, and my emergency department has a system where I would be seen by a doctor within 20 minutes of arriving for what they call a triage. And he would say, "Oh, I know exactly what you've got. Go and sit over there." And I might have to wait to get a splint put on it. But none of that would cost me anything. And that's the difference in the healthcare system. And if while I was there, I suddenly vomited blood and had to have an emergency operation, and they called my wife and said, your husband's on the operating table and so on, she wouldn't have to worry that, oh my gosh, this is going to cost us thousands of dollars and we can't afford that because we're in a lower income. I'm not, but if I was, a lower income bracket. She wouldn't even consider worrying about it because all the hospitalization, the anesthetist fees, the surgeon's fees, the antibiotic, everything is covered by the healthcare system, no matter where that happened to me in Canada. So as a healthcare user, I should be an expert on the system. But again, there is a multi-tiered system in healthcare in all countries, but certainly even in Canada. And I just gave you an example. I have access to anybody I want. If I have a problem with my knee or a headache and so on, I can call a colleague. So if you're a nurse, if you're in the healthcare system, if you're a nurse or a doctor, or you're even an orderly, you can stop a doctor in the hall and say, "Hey, my wife's got this black spot on her arm." And I would say, "Oh, take a picture on your cell phone, send it to me. If it's something worrisome, I'll see her and take it off." So that's one tier. And then there's the tier of everybody at the bottom who are covered, as I described. And their basic medication, if they're 25 or under or 65 or over, is covered. So if I go to the pharmacy to get medications, if the antibiotic would cost me $100, I pay $4.11. And you have to pay because of my income bracket, I have to pay about $200 a year for the first $200 worth of medication. After that, I don't pay anything. If my income bracket was, as most people in this bottom level is, the truck driver, the guy that sweeps the floor in the hospital, I'd have to pay for my medication because I'd probably be 35 or 40. But over 65, almost everything is covered, including the most expensive immunotherapy for malignancy that would run you $100,000 to $200,000 a year. So that's sort of the lower tier. And then there's the highest tier. There's the guys that make $2 or $3 or $4 or $5 million a year as a CEO. And if they have something, they can get the best medical care in the world because all they have to do is go to the United States. They can jump the queue. They can get their total knee done in a week. They can have anything done because they'll just pay for it. They'll pay for it out of their pocket. Now, there's a sort of a middle tier that I haven't covered, and that's the person who wants to jump the queue and wants to go to a private clinic, and there are a few in Canada, and the government will not pay for those. So people can pay out of their pocket. And there's an ongoing government versus the people argument as to whether you should be allowed to jump the queue and pay extra. And of course, the argument of most of us would be, no. If you're setting up private clinics, you're taking nurses and doctors out of the central pool. And this is what the situation is, for example, in England. taking people out of the central pool, putting them in these private clinics where they can pay them a little more and they can charge the patient as much as they want, which means it deteriorates the bottom line. So at the moment, that argument is going on in my province and elsewhere. So there's 4 tiers there. But at the moment, and the thing that I like about this system is that when I see a patient, I don't have to worry whether they're going to be able to afford the treatment I recommend, whatever it is, whether I recommend they have an operation that's going to cost $1,000 or $10,000. And I don't do these surgeries anymore. I would send it to a colleague, but I still see them and assess them. I don't have to worry about prescribing an expensive antibiotic for someone over 65 or under 25. But because every dollar I spend in the healthcare system is a dollar that's not available for something else, I'm careful what I order. There's someone who has to pay for it or whether the government has to pay for it. Because there's only so much money in the system. And that's what my wife was referring to when she said, that system's in crisis. And the governments, there are 10 provinces and 2 territories in Canada. Each province, like each state, controls the healthcare system dollars. And then they go to the federal government and say, you need to transfer more money to us so we can run the healthcare system. And they negotiate, and they just got X billions of dollars. But what the federal government has said is, right, we're going to increase the amount we give you, but it's contingent on you providing information as to how it's spent and where it goes. And this is what we want. If you're spending a lot of money on treating patients at the last month of their life, and that's where a lot of the expenses go, a 90-year-old that ends up in the ICU for 4 weeks before he or she dies, that's a lot of money from the healthcare system. If you're spending it all there and not on preventive medicine, preventing tuberculosis, making sure everybody got vaccinated, we did a really good job with COVID-19. We got a large percent of the population vaccinated very quickly, and it cost nobody anything. In fact, they provided free parking at one of our hospital areas for people to come in and line up and get their vaccine. So
we had a president that was advising people to take ivermectin, which is a drug that is given to horses to get rid of worms. So
I know
we had different issues going on here.
But in defense of your country, he put one of the good things he did. He put a lot of money into helping develop that vaccine.
Yes, you're absolutely right about that, and that was to his credit.
Yeah, and to the government's credit. I mean, yes. He can't do that by himself. So that, as I say, I should be an expert on the Canadian healthcare system, and I'm not. I've given you my perspective on it, and I'm happy to ask Jean's questions, but I'm not nearly the expert I would like to be because so much of it is done at higher levels than hospital administration. It's done in the Senate. It's done in and how they make some of the decisions they make. And one of the decisions that I disagree with is that they've negotiated with Big Pharma, big money, Big Pharma, and they were supposed to negotiate and decrease the amount we pay, you and I, the government, the provinces pay for drugs, and they sort of backed off because Big Pharma has so much money. They've been able to get to the members of parliament and say, oh, no, if you do this, we won't put as much money into research in Canada. And what you need strong individuals who will then say, nope, I'm sorry. We've got to make sure everybody can get the drugs. And what we're going through at the moment is trying to get a universal drug plan and a universal dental plan. So those people from 25 to 65 will have their drugs covered. And we desperately need a dental plan for people that can't afford to get their teeth looked after. That's coming next. Sorry, Mike, you were going to say something?
No. I was just, Gene's gonna, whenever you're done, we're gonna let Gene fire off the first round of questions.
Go, Gene.
Well, I was kind of surprised you said that approximately a fourth of Canadians don't have a primary care physician. What role do nurse practitioners have in providing primary care?
Oh, a great role, and one of the big advances that's occurred over the past decade is family health centers that have family doctors, dietitians, nurse practitioners, and they do a fabulous job because a nurse practitioner, and I now get, for example, now get consults from nurse practitioners working with a doctor. They've seen the patient for whatever reason, they felt a lump in their neck, and they have gone ahead and made the referral. I don't know whether they've discussed that with the family doctor or not. They probably have, but they make the referral and they have their own referral number that I can use to bill when I see the patient. So nurse practitioners do a great job, and there just aren't enough of them, right?
Well, we have a similar situation in rural Kentucky. A very large percentage of patients get their primary care from nurse practitioners, and nurse practitioners in Kentucky are allowed to practice independently. Do they have to practice in Canada independently, or do they have to be tightly connected with a physician?
I don't think I can answer that completely, Gene. I think in rural areas, they probably can practice independently. Remember, there are, I'm talking about Ontario, and there are 10 provinces and 2 territories. I think in the territories in particular, in the far north where there are only nurse practitioners, I think they can and do practice independently. One thing you may not know, and is brand new, is that pharmacists now in Ontario, I'm not sure about the rest of the country, certainly in Ontario, pharmacists can prescribe drugs. So if a woman goes in with a urinary tract infection, the pharmacist can give her appropriate antibiotic.
I don't think that's an unreasonable set of circumstances. I mean, I don't know if pharmacists do that in this country, but I think that's quite a reasonable way to deal with things.
I think it's awesome.
They know a lot about drugs.
Well,
right. And if you don't have a family doctor, or it's 8 o'clock at night and you've got major symptoms that can be fixed with an antibiotic that's safe and easily prescribed, and you can go to the pharmacist and pick it up, I think it's a great idea.
Yes, no question. Well, listen.
Let me just comment on that.
Okay,
that's a changing scene in America. As a matter of fact, while I was in Honduras, one of my grandkids developed a sore throat, and he took the child to one of our private pharmacies. They did a strep screen. It was positive, and they gave him antibiotics. There was a physician overseeing that, but he was not present and did not examine my grandson.
I mean, that's a major advance. That's right. They now give vaccines here, and you're quite right. They can do a swab for staff and give the child or adult the appropriate antibiotic, in this case, without contact with a family doctor. Yeah.
Well, let's go back a little bit to some of your earlier comments. I want to talk a little bit about the out-of-pocket costs in our healthcare industry as opposed to your healthcare system. Let me give you a few examples and ask you to comment on this, because I think this is one of the key reasons our systems are so different. So we have 1,000 for-profit health insurance companies, as well as Medicare and Medicaid, which are 2 government-sponsored run health insurance providers. And we have something called pre-authorization. So we have to, the 1,000 different insurance companies, they have 15 to 30 different plans. And many of these plans require that you get permission from the insurance company to do whatever you want to do, whether it's to order a CT scan or an antibiotic or schedule surgery. And the different pre-authorizations have to do with the details of the plan. Then there's a thing called a deductible, and this is the amount of money that you have to pay out of pocket before the insurance kicks in. And again, this depends on a different plan. So you've got 15, 20 plans and 1,000 insurance companies. And then there's something called a copayment. This is the amount of money you pay out of your pocket before you get seen. And let's say, for example, to see a primary care physician, it would be $30. To see a surgeon like you or me or Gene, it would be $50. And you go to the emergency room, it'd be $150. And then there's another thing called coinsurance, which is another part of the insurance. How much of that you pay until you've met your deductibles? And there's this is an insane amount of complexity here. So given the pre-authorization, the deductibles, the co-payments, and the co-insurance, how much of that exists in the Canadian health system?
I think the only place that exists is with respect to medication, as I alluded to in my talk.
Yes.
So,
okay.
And your tagline is single payer radio. There is really only one payer of doctors and nurses in Canada. Certainly by province, it's essentially the same. And that's a government fund, OHIP, Ontario Health Insurance Program. So when I see a patient, I get their OHIP number and their information, and my wife puts it into a computer and it's billed and it comes through on a monthly basis. And they pay everything. So there's no co-payment. You go to the emergency department, you never have to worry it's going to cost you anything, with maybe the exception if you might have to pay for a pair of crutches. If you sprained your ankle and you need a pair, you may have to pay for the crutches. Unless you're, there's a social network, you can say, oh, I can't, I can't afford that. And then the social worker will work that out. But other than that, there is really no co-payment. And the more levels you have between the person getting a service and the person who's got the money, all those different insurance companies, the more it costs the system.
Do you have any for-profit insurance companies, functioning in Canada?
Yes. Yeah. You can buy insurance for example, for instance, if you're going to end up in a long-term care facility, you can buy insurance over your lifetime so that is covered. You can buy insurance to cover you for drugs that aren't covered by the healthcare system. And, there are experimental drugs that are not yet approved. And I need to explain that. So the advantages that have occurred in the treatment of metastatic malignancy, for example, melanoma, lung cancer, in new treatments, specific treatments based on the genetic basis of the malignancy. They are so advanced and so amazing that when you and I were in practice and operating on melanoma, Mike, we saw a patient with metastasis in the lung or the liver. We knew they'd be dead within 3 months. They're now living years, 5 years, 10 years on these very expensive drugs. And in Ontario, before those drugs are provided free to the patient, there has to be a panel that assesses them and say, yes, the information in the literature, the information that's available say this is of benefit, and we will fund it. But they won't fund it unless it's been proven to be a benefit. In other words, now in that situation, if you've got separate insurance it will cover for those expensive drugs until the government has had a chance to approve them. Does that answer your question?
Yes, it does.
Yes, while I was in Honduras on a medical mission trip, I knew this was coming up, so I asked the other doctors what they wanted me to ask you. And it was interesting. First thing they wanted to know was, how long does it take to see a specialist, like an orthopedic surgeon or a ophthalmologist? And the second question is, if you need a total hip or a total knee, how long does it take to get that done?
Good questions. That's what my wife was alluding to when she says we've got problems with the healthcare system. As I say, I'm in the healthcare system, both as a provider as well as a recipient. And my wife has a cataract, and she saw her ophthalmologist about 4 weeks ago. And the wait time for her to see that ophthalmologist was almost 6 months. Now, a cataract is not an emergency situation. And her optometrist said, well, your cataract's getting to the stage where you're going to need to have it done. I'll book you an appointment, but it'll take, 6 months for that appointment. By then it might be ready to be done. So the wait is long. However, we weren't happy with the individual my wife saw. I went with her to that appointment and the recommendation that was given. So I called my ophthalmologist, and his response was, do you want me to see her? And I said, yes. He said, well, when the request from the optometrist comes through to the office, just phone and tell her it's your wife and I'll fit her in. That's, there's that multi-tier system. Joints, you might wait 6 months or more to get a total knee or a total hip. And interestingly, that's one of the things the Ontario government monitors, how long it takes for a given hospital from the time an orthopedic surgeon sees the patient till the patient has their operation. How long does that take? And if that wait time is beyond the acceptable, whatever that is, let's say it's going to be 6 months before the patient gets their total knee. If there's someone else somewhere else in the province that has a wait list that's only 3 months, then that they will automatically say to that patient, well, Dr. Jones can do this for you in 3 months at such and such a hospital. So the provincial system keeps track of that. The same with cataracts. So cataracts, total joints are monitored. And yes, the wait time is longer than you or I would wish if we needed a total joint. And the hospitals are paid extra money if they keep their wait time down below a certain level. Joints, cataracts, and cancer surgery. And if the wait time at the hospital for an operation, a major operation for cancer, say, is longer than 4 months, then the hospital does not get the extra bonus for doing that cancer operation. So I'm not sure I've answered your question completely, because it varies a lot from province to province.
Yeah, but on the other side of the coin, we have 30 million people in this country who are uninsured. They don't even have access to those issues. We have another, and I'm trying to remember the numbers because I had it in a talk, but I don't. There's probably another 20 or 30 million who are underinsured, who really don't have much access to it either.
I think
and as Gene mentioned, Mark mentioned in his introduction, we have over 100 million people in this country with medical debt. And the major cause of bankruptcy in this country is medical debt. So, all of your citizens have access to it. Now they have to wait a little bit. and the fat cats always get to the front of the line anyway.
Yeah.
And that's okay. I mean, I don't have a problem. I mean, you can live with that. The fact that you're underclass aren't in the same desperate situation that our underclasses are in this country.
I think it's more than 100 million who are only underinsured. Is that right, Mark? Something like that.
Yes. Gene, I don't know if it is 100 million. I don't know if it's called like 70 million, but it's what if you're one and don't have access to care, it shouldn't be happening.
There's no perfect healthcare system. I mean, I think.
Well, exactly. I mean,
Yeah, you mentioned that in the beginning, and I think
Yeah.
that's an important issue that everybody needs to accept. And then you kind of work around the issues of all of the other aspects of it.
The other questions the doctors had, do patients have to go a long distance to get specialty care, for example, chemotherapy, radiation, etc.?
so you want to know if they do? Well, we're a
Yeah.
big country, right?
Right.
I mean, early in my years, like 20 years ago, I went up to a town called Kapuskasing, way up in northern Ontario. It took me 2 flights to get there. I went there and did a locum for a couple of times, for a week at a time. And I was the only surgeon. There were only 6 family doctors, and I loved it. It was my operating room. I didn't have to wait for the orthopods to finish. I didn't have to wait for the plastic surgeon to do something. If I had something need to be done, I phoned the one family doctor that did anesthesia, and I said, I got a patient needs an appendectomy. And he said, well, can I finish my clinic? It'll take me about a half an hour. And I said, that'd be great. Instead of waiting 6 hours. But if I saw a patient, and I saw a patient that had a fractured hip, and I didn't do fractured hips, clearly. That patient was transferred down by airplane to a place where they could do the fractured hip at no cost. There is a problem for instance, in Manitoba, one of our provinces, halfway between where I'm sitting and the Pacific Ocean, for your audience, and they have a big, wide open north, and women in the north that have possible problems with pregnancy, and it's predicted they're going to have a problem with their pregnancy, they are flown down away from their family, away from their kids, to spend 2 months down in a major center waiting to have their baby because of predictable complications with their second or third or fourth pregnancy or first pregnancy. But again, that's all covered. They don't have to pay any of that. But yes, in a big country, you have to travel sometimes a long way to get specialist care.
Let's talk a little bit about the pharmaceutical industry. You mentioned it earlier. Let me give you a couple of examples about what goes on here. And I know it was my understanding that up in Canada, the Ministry of Health has a committee that reviews different drugs, their costs and their effectiveness.
Absolutely correct.
Well, we have a totally unregulated pharmaceutical industry in this country. They claim that the high cost of drugs is because of the research that needs to be done to identify, produce a drug, and go through all the process of studying it. I've been on the IRB for the University of Louisville 50 years and still on it. They spend more money on advertising. I was watching television last night with my wife, and every 20 minutes I have to listen to 15 minutes of advertising about every drug you can imagine, from something to arthritis to a laxative. It goes on and on and on. One more thing, and I'm going to ask you to comment on this. The largest government provider of health insurance, Medicare, is prevented by federal law from negotiating with the pharmaceutical industry. Now, there's some efforts to try to change that. I'm not exactly sure of that. I don't think that's happened yet. Maybe Gene knows. I don't know. That's the most insane economic policy that you can imagine. So that's what we're dealing with. Now, I know you mentioned earlier that you were having difficulty dealing with big pharma. At least you can negotiate with them. Our Medicare is unable to do that by prevented by law.
What you need, I was thinking about this about a half an hour ago. What you need, and what we all need, whatever country we're in, to make the changes for the best of the population, rather than just the 0.1% at the top, is you need somebody like a Ralph Nader or a Bernie Sanders who's got money or the backing to stand up and say, this is wrong. This has to be fixed. If you get the right people in politics, and that happens sometimes, maybe not even every generation, but if you get someone to do that and look at that particular law and say, this is wrong, this has to be fixed. And I would hope that's going to happen with that law. Yes, we can negotiate.
They are
pharma.
Saying that,
Yeah.
Ted, but the way our government is partitioned and fractionated, I don't see anything like that happening anytime soon, unfortunately.
Yeah, but that's just wrong, right? That the federal government says you can't negotiate, and that's because big pharma pours millions of dollars into the various political parties to get what they want. We cannot. Pharmaceutical companies cannot advertise on TV, newspapers, or magazines for prescription drugs in Canada. And of course, I see the ads.
What kind of advertising are they able to do? Can you give me an example? Well,
they can't. I can tell you, before we went to Punta Cana, I got back just as your audience. I don't know if I alluded to this, but yes, I was away for a week. Before we went, we thought, we better take that Dukoral so we don't get travelers' diarrhea. They can advertise for that in Canadian newspapers because it's not a prescription drug, but they cannot advertise a prescription drug.
Wow, that's fascinating.
Yeah.
Another issue that I'd be kind of curious about in Canada. What we have going on here, which is really, really scary, is private equity companies. These are rich investors investing money in healthcare facilities. 70% of the nursing homes in this country are owned now by private equity companies. They're buying up hospital systems. They're buying up physician practices. They anticipate getting 10 to 15% return on investment a year, and often want to sell their investment in 5 or 6 years and move on to something else. This is not meant to be a happy marriage. Is anything like that going on in Canada?
Yes. Companies buy and control long-term care facilities, nursing homes. And you're absolutely right. Their interest is in the bottom line. So the nurses or nursing aides that work in those long-term care facilities don't have benefits because they only give them part-time work. So they have to work 2 jobs, 3 jobs. I don't know about an equity firm, if that's the right term, but for example, the long-term care facility my mom was in, and it was a very good one, and she paid X amount per month. But it was owned by a private company. And the government is looking very carefully at the long-term care facility. And hopefully none of us on this Zoom, none of the 4 of us, and hopefully maybe none of your listeners will end up in a long-term care facility, because what happened during COVID in the long-term care facilities, nursing homes throughout the world, certainly in Canada, was a disaster. And that has focused the attention of the public and the government on these long-term care facilities. And the government is looking very carefully at deciding whether they should be responsible for all the long-term care facilities, not just the public ones, but the ones that are run for profit. There are some private facilities that are owned by companies for profit, standalone facilities to do surgery, for instance, plastic surgery that is not covered. And those individuals are clearly doing that for profit. And there's nothing wrong with making a profit when you do. I mean, we all expect to be paid adequately for what we do, but the long-term care nursing home facility problem is here too.
Well, it's not just long-term care facilities, that there are huge hospital systems that are now owned and run by private equity companies.
Yeah.
They let me give you an example. Just, one of the kind of insane things that happened. There's a large dermatology practice in California, and it was purchased by a private equity company, and they basically run the non-medical component of it. So they order the drugs, the toilet paper, and hire the staff, do a lot of things like encouraging the staff to upcode so that the bills are higher. And in this one particular case, the management ordered some new equipment, and they ordered a different brand of needles, and the without consulting the medical staff. And when the dermatologist would put the needle onto the syringe and inject the local anesthesia into the skin, the tip of the needle would break off because it was such an product. And they had to take the tip of the needle out of the skin. So, there's a lot of that kind of stuff that goes on. It's really scary how much of that, Gene, we were talking about was horizontal and vertical integration. Gene's got some information about some of the things that the pharmaceutical company CVS is buying the health insurance company, and they're going to set medical practices up in the drugstores.
Yes, that's going on more than just CVS. CVS owns Aetna. They own Signify Health. They just bought a large physician group. Walgreens is doing that. Humana is seriously considering it. I don't mean Humana, Walmart. Even Amazon's getting into the healthcare business. We're rapidly headed for a totally for-profit system. I have a couple other questions that I'm interested in. We talk a lot about burnout among physicians and nurses in the U.S. Do you have a similar problem in Canada?
Oh yeah. And that's one of the problems getting access to healthcare at the moment, and has been throughout COVID. I mean, I had colleagues who were put in charge of COVID wards, and they retired. They said, "Look, I can't do that. I'm 65. I've got some heart problems, lung problems. I can't possibly take the increased risk of getting COVID. And I've worked for 35 years, and I'm tired. I'm retiring." So we lost some people. We lost some good doctors. We lost some good nurses because of the COVID crisis. And of course, the more people you lose, the fewer there are to take up that slack. So you can find an article on burnout in every medical journal that I get every month. Letters to the editor, comments from doctors, comments from nurses. the Provincial Nursing Society says that is the main problem for nurses now. Not salary, although that's obviously always a problem, but burnout. They just feel stressed, and they say, "Look, I'll come back and work part-time, but I'm not going to do this." Doctors for sure.
Are they?
I mean, I still like. I'm Mike's age, so I'm well over 70. So I still like what I'm doing, and I enjoy it. And it's as I said before, I get to spend time with patients on the phone or in person that I never had time to do when I was a busy surgeon. But I have colleagues who say they can tell me exactly how many days they have left to go until they retire because they're burnt out now, operating at night, seeing patients that emerge, seeing people sick day after day after day.
Is the Canadian system trying to increase the number of medical students? And do the medical students have to pay for their education?
Yes, medical students pay for their education. A significant number of them who are not well off get bursaries, scholarships, but the amount they have to pay, and I don't know what it is now, but the amount they have to pay is markedly less than it is south of the border, south of that 49th parallel.
I remember from a grand rounds that was done a few years ago that the average medical student at the end of their medical school is carrying $125,000 educational debt.
It's more than that now. It's more like 250.
Oh, wow. Okay. Well,
yeah, that I would think in Canada, excluding residency, that would be a third of that, but I don't really know. I know it's nowhere near that. You had a second part to that question, Gene. Do they have to pay? What was the first part? Oh, expanding medical student. The problem, one of the problems we have, and why we're a little short of doctors now, is that there was a report paid for by the government about 15 years ago. The government was concerned about how much money it was costing and so on in Ontario. And the report came back and they said, well, the thing is, what you need to do is decrease the number of medical students you accept into medical school. And then you'll have less doctors billing the healthcare system in the next 10 to 15 years. And they actually listened, and that's what they did. And of course, predictable results. All of a sudden, you didn't have enough doctors a decade later. So that's now been reversed, and the number of medical students has increased. And what they've recently done across the country is accepted an increasing number of foreign graduates who were well trained in their country, whether it was India or Afghanistan or whatever, who were fully qualified to do medicine, but ended up driving taxis. So they're fast tracking the time it takes for someone with that background to get licensed in Canada. And what they're going to do, I think, and it's on its way in the next couple of months, is if you get a license in Ontario, you can go and practice anywhere across the country. And that's a big deal, because if you've got a guy, someone who graduates and gets a fellowship in general surgery, and he isn't needed in Hamilton, or he's trying to get a job doing a fellowship, he can go partway across the country and do a locum for a month without having to do another licensing, so on. So,
well, let's switch horses a little bit and talk about medical. We got 5 minutes left, but so we'll have to talk fast. But Mark mentioned in the beginning that we have over 100 million people in medical debt in this country, and we talked about that a little bit earlier. And the main cause of filing for bankruptcy in this country, 60%, is the inability to pay the medical bills. How much of that is an issue? In France in 2017, there was one one finger up in the air, one medical bankruptcy with 70 million people, and we in this country anywhere from 200 to 800,000 people are filing for bankruptcy. It varies in different years. How much of an issue is that up in Canada, or is it an issue at all?
I would have, a couple of years ago, I would have said it was not an issue. However, my brother, who is a politician, both provincially and then federally, and has written 2 books, the most recent one that's just out, says bankruptcy secondary to medical bills is significant in Canada. I said, how could that be? He said, drug costs. You know, special drugs. You know, if you're 50, your drugs aren't covered in Canada. So if you end up with a big bill for chemotherapy or immunotherapy and so on, that may be the cause of your bankruptcy. So it's not insignificant in Canada, but it's not because you need an operation or need hospitalization. It's because of the cost of some drugs. And the government, the next step is to provide dental care to anybody that needs it and can't afford it. And the next step is to expand the drug benefits. You can get your drugs free up to 25 in Canada and it's over 65 with rare exceptions. And in British Columbia, and if it goes in one province, it'll be everywhere, birth control pill is now free to all women. Birth control pills.
I have a question, another question about burnout. In this country, there's constant complaint about electronic medical records. A lot of physicians actually have retired because they can't deal with electronic medical records. And we have young people who are very, very good at it, but they're still spending 3 or 4 hours a day doing their medical records. How big of a problem is that in Canada?
Oh, you've nailed it on the head. The Epic system, which is fabulous, the medical record system, but it's just got so much stuff in it. And because I decided I wasn't going to retire, I became determined to learn how to do it. And I've had to do it in 2 different systems in the same city, but they now talk to each other. And I was appalled 4 years ago. We were making rounds after we got this Epic electronic system in the hospital to be making rounds with residents, and they had these platforms and computers. They weren't looking at the patient. They were looking at the computer. They're busy typing stuff on the computer and typing, and most of their notes are just actually a copy of the note in the day before, a copy of the lab results. I said, you know what, if you don't look at the patient, you won't notice that the urine in the bag is really dark because either they've got liver failure or they're hypovolemic. If you don't look at the patient, look at the turgor of their skin, if you don't see what they look like, you got to stop looking at the computer. They have to do that because you have to enter all that data in. However, once you've learned the system, it is very, very good for patient care. It will get simpler. And I know it'll get simpler because I now, when I see a patient, I dictate my note either directly into the computer or into my cell phone. I can do it from home. I can dictate a note, and within seconds, everybody that I send a copy of that note to knows what the status of that patient is.
Please go to our listeners. Number 1, thanks for listening. And number 2, please, if you haven't given, reconsider. Go to forwardradio.org,